Well, hello there. This is Professor White, and welcome to our lecture on antilipemic drugs. So LDL and triglycerides, they are both types of fat that are in the blood that increases the risk of heart disease and stroke if levels are too high. So low-density lipoprotein is a type of a fatty substance that carries cholesterol in the blood. And triglycerides are a type of fat that carries energy in the cells. So remember that high levels of triglycerides and LDL can increase the risk of heart attack and stroke. There's also a bit of difference in how the levels become elevated, and some of it may be familial, but high LDL levels are generally caused by eating red and processed meats, full-fat dairies, fast food, fried foods, some sweets. High triglyceride levels, on the other hand, are caused by eating more calories than are burned, being overweight, smoking, excessive alcohol use, certain medicines, genetic disorders, thyroid disorders, and poorly controlled type 2 diabetes. So looking at the lipoproteins, we have the very low density lipoprotein, which is made in the liver and transports the triglycerides out of the liver. And once they get to a certain density, those triglycerides, they become a low density lipoprotein. So that is known as the bad cholesterol. All right, so the LDL. Now the high density lipoproteins, they actually work to remove the excess cholesterol, and they're known as the good cholesterol. So they're sort of like the recyclers, and everybody likes people who recycle. So that's why we know HDL, we'd want them to be higher. And here's the complete cycle. So we have the liver with the very low density lipoproteins, which change into low density lipoproteins, which then go to the cell, cholesterol into the cell. Reminder that the cells need cholesterol to function. That's part of what they require to survive. And then HDL comes and removes the excess cholesterol, and the liver converts that HDL into bile salts, and then we start the whole process over again. So the big concern here is the plaques that can form as a result of too many lipoproteins. This is the leading cause of cardiovascular heart disease, right? So basically, when the cholesterol is circulating, when there's too much of it, it adheres to the heart vessels, and basically even our macrophage cells, they get formed, they're filled with fat, and as you can see that the vessels narrow, and we'll have a hard time getting blood supply to those very important tissues. The big concern with elevated levels of cholesterol is the link to heart disease. So as you can see here, patients with cholesterol levels of 300 are almost 3 to 4 times more likely to have coronary artery disease than those who keep those levels under 200. Our mainstay of treatment are the antilipemic drugs, but they cannot be used alone. They are to be used along with a healthy lifestyle choices, including diets. Phenotyping is what we use to decide the lipid profile of the patient and which medications would be the most beneficial for them based on their mix of different cholesterols. In patients who are generally healthy but have elevated levels of cholesterol in their blood, it's recommended that they start on diet and exercise for at least 6 months before going into medications. Working with patients in the hospital and cardiac patients, one thing I will tell you is that if we have somebody who already has a known cardiac disease process going on, already has atherosclerosis, and they have some sort of a cardiac event or hypertension, or they have angina, that they will not wait the 6 months to start treatment because they want to get those cholesterol levels down, because we already know then that we have a patient who's got the more than just the risk factors for coronary artery disease, they have them. But for everyone else, 6 months of diet and exercise before the medications are considered. And that's because, guys, medications have a lot of side effects. Even if we give a certain medication to every patient that you might have in the hospital, it doesn't mean they are not without their side effects. All right, the first class of medications we're going to talk about are the statin drugs, or technically they're HMG CoA reductase inhibitors, or HMG inhibitors, but they're known as the statins. That's because they all end with statin in their name. So this is generally first-line treatment if our lifestyle modifications aren't giving the results that are needed. These lower the rate of cholesterol production, and they can reduce the LDL levels by up to 50%, increase HDL levels up to 15%, and reduce triglycerides 10 to 30%. So the most potent LDL reducers that we have out there are lovastatin, pravastatin, simvastatin, atorvastatin. So these are very, very common medications that you will be giving. One thing to note, though, is that our patients may not experience the maximum benefit of the medication until up to 8 weeks after, generally 6 to 8 weeks after they initiate therapy with these medications. So there's your indications for it. So anybody with cardiovascular disease, which we've already said, LDLs greater than 190. If they're diabetic, age 40 to 75, and their LDLs are 70 to 189, if they don't have heart disease, and if they have an LDL between 70 and 189, and they have a higher than average risk factor for cardiovascular disease, regardless of their status. So this takes into account other factors like smoking, family history, some other sort of risk factors they may have. All right, so adverse effects of the statins. There's a mnemonic here for you for the statin side effects, HMG-CoA, which is hepatotoxicity and headache. Understand that these antilipemic drugs as classes are generally metabolized in the liver and can cause liver impairment. So be aware of that. Myalgia, myopathy. So this is why we teach patients to let us know if they're having any muscle pain, because it can lead to a serious condition that's called rhabdomyolysis, which we'll look at in the next slide. There's some GI effects, so mild and transient, so diarrhea and flatulence. CPK increases, and that goes along with the myopathy and muscle breakdown, and these should be avoided in pregnancy. Rhabdomyolysis is the breakdown of muscle protein, and the statin drugs are one of those classes of medications that can cause this myopathy. And if that's the case, if muscles are being broken down, that allows the myoglobin, which is the muscle cells, to leak into the bloodstream, and they go right to the kidneys. They can cause kidney failure, even kill a patient. And we will see signs. So that's what you see there in the urine is myoglobinuria. So you can see that darker urine. Sometimes it's even darker than that, often described as like a Coca-Cola urine. So they need to make sure to report any unexplained muscle pain or discomfort to the healthcare provider immediately. Let us know if they have changes in their urine color or any other concern related to myopathies. And because I like pictures, here's the picture for you guys about myoglobin and what it does to the kidneys, because as you know, the kidneys for me are precious, precious angels, and we should not be damaging them if we can help it. All right, some of the interactions that we might need to consider are that, and hear me out on this, statins and oral anticoagulants are often prescribed together, but there are some things to consider. The first one is the bleeding risk, right? So some studies have raised concerns that taking statins with our DOACs can increase the risk of major bleeding and also intracerebral hemorrhage. However, studies have found that statins may also reduce the risk of bleeding and patients who are basically taking DOACs that don't have AFib. But statins also affect anticoagulation with Coumadin and can increase the risk of bleeding. And a very interesting study had come out and said that statin therapy actually reduces the risk of dementia in AFib patients who take oral anticoagulants. So there's a lot to swallow in there, but the main takeaway is that there's an increased risk of bleeding if the patient is taking oral anticoagulants as well as statins. Some of the other interactions have to do with CYP3A4. So those medications that are listed here are ones that are metabolized by that part of the liver. And one of the big ones there is grapefruit juice. So basically, components in the grapefruit juice, they actually inactivate that CYP3A4 in the liver and the intestines. And we need that enzyme for statin metabolism. So as a result of that, a person may have increased risk of toxicity, including that myopathy, which leads to rhabdomyolysis. So that's why we don't have them take grapefruit juice, and they should avoid it. Here is one of the prototype drugs for you. This is atorvastatin, very commonly used in this class, and it works on LDL as well as triglycerides and raises the good HDL. And it's usually taken at bedtime or in the evening, and that's to correlate with this diurnal rhythm, like the day-night cycle of metabolism. However, I've got to be honest with you, despite knowing that, most of the time we're giving this statin drugs in the morning with our morning med pass these days. But in a perfect world, we would give it in the evening. Another drug in this class is simvastatin, and basically simvastatin has a lot of drug interactions that require dosing adjustments and can work to raise HDL, but it really works on the LDL and triglycerides. Some of the things about dosing adjustments is that for this medication, the initial dose is 10 to 20 milligrams once a day. If a patient is really high risk, they may initiate at 40 milligrams. But because of the huge risk of myopathy, that the only people who can be on the maximum dose of 80 milligrams a day are those patients who have been taking the drug chronically for 12 months or more without any evidence of muscle toxicity. For these antilipemic, the statin drugs, we really should be checking their labs about 4 weeks after initiating therapy, but at least 4 weeks, but at least by 8 weeks. And if they're unable to reach their goals, then they should be placed on an alternative medication. All right, the next group that we're going to talk about for cholesterol lowering is the bile acid sequestrants. So if you recall back up in the presentation, we talked about the liver converting HDL into bile salts. So these bile acid sequestrants can help reduce the levels of cholesterol. Some of the most common ones would be cholestyramine or questran, and these ones are generally in a powdered form that has to be mixed up and taken in total. So sometimes they cause a lot of GI discomfort and they're not very well tolerated. So what they do is they prevent the reabsorption of bile acids in the small intestine, and bile acids are necessary to absorb cholesterol, so that's how they work. They are considered second line after statins. And here are the indications. So they may be used right along with statins. Again, if they're not getting the therapeutic response on a statin, this could be added over to it as well. Some of the more common adverse effects include constipation, heartburn, nausea, some GI discomfort. They tend to get better over time. And the recommendation is to increase the dietary fiber or take a fiber supplement to help with the constipation and bloating. And these may also cause mild increases in the triglycerides. So bear that in mind as we deal with patients, maybe they have already high triglycerides. Some of the other adverse effects would be tinnitus, or that ringing of the ears. The urine may have a burnt odor, and headaches are also very possible with these sequestrants. Here's the big issue with these medications. So they can cause GI obstructions, so they can cause bowel obstructions, and the biggest interaction that they have is that these medications, once they're mixed in, that the patient will drink the medication, and whatever else that they take that's water soluble, fats, like anything, basically, it will be absorbed into these sequestrants and pass through the GI system unmetabolized. So the other issue is our fat-soluble vitamins. If the person is taking these bile acid sequestrants in these higher dosage, then their fat-soluble vitamins, which you see listed here, vitamins A, D, E, and K, which are hugely important to us, they are not going to be absorbed as well. So here is your exemplar drug. It's cholestyramine or Questran. So big contraindication is phenylketonuria. If the patient is pregnant, then they're going to need to take additional vitamin K to prevent that complication in the newborn. And for the powder, you have to be very careful with it. It may not even mix completely at first, but patients should be taught to mix it as much as possible and then dilute whatever is undissolved with additional fluid. You have to dissolve it for at least a full minute. All right, so niacin is vitamin B3. This is given in higher doses than what you would expect for just the vitamin B supplementation. It's available pretty widely. It's not very expensive, and basically it works on lipase. So remember, lipase will break down lipids. So if we increase the breakdown of lipids, then we're in the money there. So that is good. In fact, the one thing I will tell you, if you look at a lot of your energy drinks like and like pre-workouts like C4 and things like that, they actually have niacin in them. The reason I mention that is I can recall taking a pre-workout, taking C4 and having the immediate flushing and looking at the dose of niacin that was in it, and I'm like, duh, of course that was going to happen. So one of the most common adverse effects is this flushing. It's caused by those histamines being released, and basically itching, cutaneous flushing, a little bit of GI issues. And these undesirable effects can be minimized by a couple things. First is starting at a lower dose. Second is taking it with the meals. The third is, and probably the most commonly prescribed for the patients, is to tell them to take a small dose of an aspirin or an NSAID with the drug or 30 minutes prior to minimize that flushing feeling. So the next time you're thinking about taking a pre-workout and you get that flushing, you should ask yourself, why am I flushing? It's probably the niacin. The next class of medications are going to be our fibric acid derivatives. So these ones are for patients who have high triglyceride levels. Although it has actions on the other cholesterols, the main focus of this medication would be on the triglycerides. So the most common medications would be gemfibrozole and fenofibrate. So you can see they both have fib in there. Contraindications are listed here for liver and kidney disease, cirrhosis, any gallbladder issues. Some of the adverse effects that may occur, these medications can cause nausea, vomiting, diarrhea, drowsiness, dizziness, gallstones, and it can elevate our PTT or bleeding times and also elevate liver enzymes. As you've probably guessed, using these fibric acid derivatives with oral anticoagulants can increase the effects of some of these blood thinners, so that can cause an increase in the risk of bleeding. If taken along with statins, there's an increased risk of rhabdomyolysis and that myoglobinuria, so myalgia, breaking down of that muscles, and also can affect some of our labs here. So it can decrease at the hemoglobin, hematocrit, and the white blood cell counts, and it can also increase bleeding times, cause elevated LDH levels, and bilirubin, so the liver. And now in the class called cholesterol absorption inhibitors, there's just one drug to see here, and this is Zetia or ezetimibe. So this inhibits the absorption of cholesterol in the small intestine, which decreases our total cholesterol, the LDLs, and the triglycerides, can increase HDL. Although it can be used as monotherapy, it's generally taken alongside with a statin drug. That's what you need to know about that one. And so these are a bunch of the newer classes, just something to be made aware of. They're not very commonly prescribed at this time. Again, our most common drugs are going to be your statins, followed by the other ones that we discussed here. But so now we have some sub-Q injection medications. We have something called triglyceride transfer protein inhibitors, things that work on certain enzymes. And so they're pretty interesting. We'll take a look at just one of them here. So the exemplar in these newer drugs is going to be alirocumab or Praluent. I'm not sure if I'm saying that correct, but this is a monoclonal antibody, and I do like monoclonal antibodies as a class of drugs because what they do is they always tell you what they are. Look at, you can see its name here. So let me just go back into that. So they say MAB at the end. So this is given by injection subcutaneously every 2 to 4 weeks, super duper expensive, and it has a lot of adverse effects, and look at that, can cause influenza, myalgias, and cough. So you're not going to see this often, at least not at this time, but who knows what will happen in the future. All right, let's take a look at some of the herbal remedies that are used for high cholesterol levels. So the first one is garlic. This is taken by a lot of people for their cardiovascular health, and the adverse effects are listed here. But again, we've spoken about this under our herbals supplement and things like that, but lots of interactions, especially with warfarin and NSAIDs. So basically, when using garlic, it's the recommendation really is to avoid any other drugs that are going to interfere with platelet and clotting function. And that would include antiplatelets, anticoagulants, NSAIDs, and aspirin. Flax is also an herbal supplement that's used to help with the hypercholesterolemia, so to lower cholesterol. There are a lot of interactions, anticoagulants, antiplatelets, blood pressure drugs, so diabetes drugs. In the case of diabetes drugs, it can cause blood sugar levels to drop too low. So that is something to be aware of. Increased risk of bleeding with anticoagulants can cause lowered blood pressure, which can be an issue if you're combining it with other medications to lower blood pressure, and also may decrease the effects of oral contraceptives and estrogen replacement therapy. And something that I don't know if it said it in your text, but flaxseed can actually decrease the absorption of oral medications as well. So we would ask patients to consider taking them about an hour apart from their other medications if they're taking this product. All right, so the last herbal product that's available over the counter are these omega-3 fatty acids, so often given as a fish oil supplement. And they're actually falling out of favor. They're proving to not be beneficial for most people. And the research is showing that fish oil supplements actually can increase the risk of stroke and heart disease in healthy adults. And that's because it can increase the risk of bleeding and disrupt the balance of fatty acids in the body. And for most people, there's really no cardiovascular benefit. And in fact, at high doses can cause atrial fibrillation. But despite all this, fish oil supplements may be beneficial for people who already have cardiovascular disease. It may slow progression of cardiovascular disease and decrease the risk of death. However, I worked with a doctor, and he used to be so funny because he would say to me, and I still believe it now to this day, that he said most people, the only experience they get from taking fish oil supplementation is fish smelling burps. So as an aside to that, that can be reduced by keeping these fish oil products in the freezer, if not contraindicated by the manufacturer, but that would help with the taste and the smell and everything else, and even the burping. All right, so let's wrap this section up. A lot of the nursing implications. So of course, any patient that's about to start in an antilipemic drug, let's look at their past medical history, their medications that they're on, lifestyle assessment. Can they exercise more? Are they overweight? Are there risk factors that are modifiable that we can work on? These antilipemic drugs may adversely affect liver function, and therefore liver function studies need to be closely monitored, and we would not give these medications in the case of liver disease. Patient may need fat-soluble vitamin supplement, especially with our drugs like Questran. So imagine that. Some of the side effects include constipation, and so we can work on preventing constipation by encouraging diets that are plentiful with fiber and fruit and bran, increasing fluids, as long as there's no contraindication to increasing fluids, and make sure that we teach the patients to take any powder forms the correct way. Never just take the powder by itself. Also teaching the patient about some of the most serious side effects, including myalgias and myopathies, the signs of liver dysfunction. So things that patients should be reporting to their provider would include things like abnormal or unusual bleeding, any jaundice or yellow discoloration of their skin, or any new or worsening muscle pain. There's a lot of interactions among this class of medications of the antilipemics, and many of them, taking them with food, can reduce the GI effects. All right, guys, so thank you once again for sticking with me through another lecture on another group of meds, and I'll leave you today with my cartoon, which is says whenever your cholesterol gets too high, a sensor will send out a signal that automatically locks the kitchen door and turns on your treadmill. All right, guys, thank you and have a great day.